What I wanted to do was just spend the next 20, 25 minutes just telling you what is happening in procurement in the centre and what we hope to see happen across the NHS over the next few years. There's no doubt we are facing some major challenges, and I'm just going to take you through some of those challenges in just a moment. But there's also no doubt that procurement has suddenly found itself at the forefront of these challenges, and I'll explain why that is. But before I do that, this is something that Will Cavendish recently put up. Will Cavendish is the new Director General in the Department for Innovation, Growth and Technology, and it's quite interesting that we've now got a new director in the Department of Health looking after those issues, and it probably tells you a lot about what the Department and Ministers are thinking about those important things of innovation, growth in the economy and technology. And this is a slide that Will put up. And it was just to remind us, actually, that the NHS is not bad. It's pretty good. This is some recent data. On a number of fronts, the NHS comes out number one. And we shouldn't just lose sight of that, even though we know there are lots of things that need to be done. Where it falls down is in things like equity and in timeliness of care. But we know those challenges, and we know that a lot of us are doing things about them. The issue, though, is that the finances, the government finances, are not so good. We all know that. We all know the deficit that the government have been dealing with for the last 5 years. What probably is not so clear is that in protecting the health budget, it has a major impact on other government departments, and this is probably not so widely known. And when we say protecting the health budget, we're just literally talking about it standing still for the last 4 or 5 years, which is actually unheard of in the NHS since 1948. But just that happening has a major impact on other government departments, and some of them are being cut 25, 30, 40%. So in the next government, just to protect the health budget has a major impact on other government departments, and it's really important to understand that. And of course, whilst we've got these cuts, we've got the other issue that technology and innovation is changing all around us. And again, we're all personally aware of this. Devices, new devices, your iPhones, all those kind of things, dramatically changing the way we do things. Lots of new discoveries around medicine and medical technologies, all that seem to add cost. And of course, services, media services themselves are dramatically changing the way we look at the world. And there's a view that health has been unable to embrace these technologies, and I'll leave you to decide that. But I think it's certainly true that the health system has struggled to embrace some of these technologies, which now we just accept as the norm in our sort of private lives. And interestingly, although I've said the NHS tends to be up there as number one, and actually it is the most cost-effective health system in the world, but actually, is it improving itself in terms of its own efficiency? And the answer to that is that the efficiency in the NHS has stayed pretty much flat for the last 4 or 5 years. And that contrasts with other countries like Denmark, where efficiency improvement has been around the order of 12%. So there's still some big issues about how the NHS can move forward, embracing technology, embracing innovation, and becoming more efficient. And again, those of you who work in hospitals, I think you would accept there's still a lot of paper in the system. And I was as a senior civil servant, we're now mandated to do 20 days on the front line to find out what it's really like in a hospital. And a couple of weeks ago, I had the opportunity to go and work in a hospital, doing everything from the portering to being in the operating theatre. I was just struck by the paper, particularly around medical records. I spent a day in the medical records department. I just couldn't believe it. And when you see that and you see the technology, you really start to wonder what it is that's holding us back. Okay. Obviously, Simon Stevens has set his stall out that things need to change, and I'm sure we've all read that document, the 5-year forward view. I kind of felt he had to say this with an election looming next year, and saying that you can't carry on doing what you're doing, and there does need to be investment in the NHS. So he really had to say that, didn't he? As governments start to think about their policies with the forthcoming election. But he says, that you've really got to tackle the three areas of demand, of efficiency and funding. All three have to be tackled. You can't just tackle one of them. And that's a huge challenge for the NHS. I'm going to focus on one of those challenges, which is the challenge of efficiency. So given that as a bit of a backdrop, so really a struggle to embrace technology, innovation, funding is going to get tighter, but it's beginning to really bite now in the NHS. The end of last financial year was the first time for a long time that the overall provider sector in the NHS, that's the foundation trust and non-foundation trusts, ended up with a deficit. The worrying thing was that wasn't a planned deficit. There was a planned surplus of around, I think it was around about 300 million, but the whole sector ended up with a £100 million deficit. So something is really happening here in terms of finances in the system. And I'm just going to take you through some numbers in a minute, and this year is going to be even more challenging, and we're going to find a lot of NHS trusts in financial deficit at the end of this financial year. The second thing is the non-pay spend of NHS trusts. This is the money that the trusts spend on goods and services, which is typically around about 30% of their operating expenses, has been going up at an alarming rate. Over the period of 2010-11 to 2012-13, it was going up at around about £2 billion a year, so 10% per year. I don't know the figures yet for last financial year. We think it's slowed down a bit, which is good news, but actually that's quite an alarming jump year on year. And you could say, okay, that could be because activity is increasing. That might be true. The economists in the Department of Health tell me that activity has been running about 2.93%, but this is 10%. So what is going on? Is it inflation? Is it the issues of technology and so forth? And to be honest, we don't know. We really don't know. There are some figures that you could highlight in there, and probably the biggest issue you could highlight in there is the increase in the expenditure on agency staff. And there are good reasons for that. Following the Francis report, a lot of trusts now increasing their staffing levels, using agency staff to do that. And that has meant that it's jumped from 2.4 billion in 2010-11, and it's now approaching 5 billion. And that is, in itself has put huge pressure on the finances of hospitals. And of course, and I'm sure you've seen it in the press, lots and lots of reports now about financial problems. The Guardian saying the NHS is facing a deficit towards £1 billion. And Monitor itself have openly said, I'll just show you some data in a minute that they published earlier this year, that the foundation trust sector is not immune from this either. So it's not just the usual trusts that have always had problems financially. And this little graph on the bottom here, a little document called Into the Red, the State of NHS Finances, is also quite interesting because it shows you that actually most trusts are going to be in the red. It's really just the large teaching acutes that are going to be in the black. So you're just starting to see the market or the NHS system change quite dramatically. Monitor produced a report a month or so ago, probably a couple of months ago now, which was just the first quarter of this financial year for the foundation trusts. And again, some really alarming figures here. For the first quarter, 80% of acute foundation trusts were in deficit. So, as I said, it's not just the non-foundation trusts here. The foundation trust sector is equally feeling the pinch on this. And that deficits of 227 million were predicted from 86 foundation trusts. So this year is going to be a particularly challenging year. So ministers, wondering what to do about this, and difficult period with an election coming next year, clearly want to see action. And guess what? Procurement is the answer. It's seen as the pain-free solution, basically. You can easily go and beat a few suppliers up in low prices, and hey presto, we solve the NHS's financial problems. Of course, it doesn't work like that, but that is a view and a perception that ministers have about procurement in the NHS. And on the left here, Jeremy Hunt had an idea one Friday night. I got a call on a Friday night early, back in, I think it was March or April, that he wanted to make an announcement on the Andrew Marr show on the Sunday, that what we really need is why can't we have a core list of products, basic products, then you should just buy them, we shouldn't be arguing about it. And he wanted to announce that on the Andrew Marr show on the Fridays, on the Sunday, and he was asking why he couldn't do it. I gave him lots of reasons why he could do it, and what he should say, which he ignored. And actually, he announced, we're going to have a core list of products for the NHS that's going to cover something like 3 billion of spend, and it will save the NHS 500 million. And that's what he said. So since then, we've been frantically trying to work out how you make that happen. And I'll talk about that a bit later on. But again, it's just that perception, that expectation that ministers have that this is easy to do. Dan Poulter, when we published the Better Procurement document last year, said we need more of a bargain hunt approach. And I have absolutely no idea what he meant by that. And I've asked him, and I still don't understand what he means by that at all. But it's just interesting, again, that ministers have a strong view about procurement and what could be done. And the final thing I want to mention is a chap called Lord Carter, which I will come back to in just a second, because he has changed quite a lot of our thinking around what we could do in procurement in the NHS. But before I do that, and I know lots of people in this room have heard me say this before, just to go back over old ground a little bit about, given that context, there are still lots of issues that we've got to deal with in procurement. And I feel kind of guilty putting these things up now because it's old. This is 2011 that the NEO produced their report, and there was a Public Accounts Committee. I have been out and about around the NHS, and I have seen some fantastic stuff going on in procurement in the NHS. So I also feel guilty putting this up because it's kind of quite critical of procurement in the NHS. I have to say, though, there is still a lot of this that does exist. But there are some fantastic trusts doing some really good work, so let me just put that in context. But generally speaking, this is true in a lot of trusts. There is still that lack of leadership. Data and information is not as good as it could be. There is huge variation. There's no doubt about that. Huge variation in the products used, huge variation in the prices being paid. I think the NEO quoted, I think it was latex examination gloves, it usually is, usually rubber gloves, it always tends to come down to rubber gloves at some stage. But they were quoting, some trusts having, I don't know, a dozen types of examination gloves, another trust having 346, I think that was the number. Which does seem, even if, there might be good reasons for that variation, it does seem an extreme number. And actually, 3 or 4 years ago, it was absolutely true. There was a culture of not really sharing across the system. Following the disbanding of PASA, trusts really were not sharing information. I'm pleased to say that's no longer the case, and we're now really starting to see some sharing of information and working together across the system, and I think that's fantastic to see. But the landscape itself in procurement is still incredibly confusing because we have built one policy on top of another, and we've got organisations, some that are legacies of previous policies. It's just not clear how they work together, and actually that they compete. And you could argue that's a good thing, and it's not. It might be a good thing, but you could argue it creates a lot of confusion, a lot of replication. Trusts don't quite know who to use, and of course suppliers don't know who which trusts these organisations represent. So you're not really going to give these organisations the best prices. And that's, I guess you all know this. That's what the landscape looks like currently. We've got a right mixture of some national organisations such as Supply Chain and the Crown Commercial Service, which between them cover around 3.5 to 4 billion of the 22 billion that I was talking about earlier. We've got a range of collaborative organisations, some of which are, I guess you could say, owned by the NHS because the trust pay fees to be part of that club. But some of them have become private sector, such as the one in the Northwest, which joined up with the Shared Business Service, which is actually half owned by the Department of Health, interestingly enough. So we own half of that organising figure. It's kind of a bizarre situation that we've got, the other half being owned by Steria. And you've got one that was gone wholly over to the private sector, which was the West Midlands hub that became Health Trust Europe after it was acquired by the HCA Group, so an American hospital organisation. So we've got a GPO, a group purchasing organisation, really, in the UK. So you've got a right mix here of organisations. And there's good and bad in this, and I wouldn't want to be critical of any of these organisations, because they're all doing good stuff. But it must be confusing to the landscape, and it must be confusing to suppliers. So I'm sure you can make your own mind about that. Where does the money go? The health budget now is about 120 billion. Three-quarters of it actually goes to the providers. So our focus really has been on the providers, on the hospitals. And when you break that down, this is the provider spend, the 22 billion. Most of it is staff, and the others are the sort of 22 billion. And there's a bit of a view that, the state of the NHS finances as they are, can you just focus on that third? Should you not also be looking at the big blue chunk as well? Because really, to deliver the kind of savings that we need to see in the system, you need to look at the whole thing. And that's probably where Lord Carter comes in. I'm not going to labour this, because I know David's talking about supply chain in just a second. So, but the supply chain contract is there. I'm going to come back to it a bit later on about some of our thoughts about that. But that's what supply chain does. So, given all of that context, we published a strategy last August. And it's really been fantastic to have a minister that's been really interested in this. It's not something I've been used to in procurement in the NHS. And Dan Poulter, he's actually seen this as his main priority, which is interesting. I did find myself one Friday afternoon sitting down with him for about 3 hours, going through this document word by word, and I've never known a minister have that level of interest in it. I think that's a really, really good thing. But the interesting thing about this document is that it was inevitable that there was going to be pressure for some top-down initiatives to save money, mainly because of Treasury's involvement in this, because of Cabinet Officer's involvement in this. But I was adamant all along that I accept that has to happen, but it's also about the trust themselves, and we need to help the trust develop those three things of better leadership, improving the capability and capacity in the system for better procurement, and improving the data. Because unless you fix those three things, any top-down initiative just dissipates. And I've seen that so many times over 30 years I've been in the NHS. So this document was a combination of those two things: some top-down stuff and some stuff to really enable and help trust improve themselves. And that's what we've been working on. And then along comes this chap. Very interesting chap. We did say in that better procurement document, and this was Secretary of State's view, that we needed some kind of big-hitting champion for all of this, for the system. And it took us 9 months to get somebody in and get him over the line. But now Lord Patrick Carter is fully on board. And the first thing he said, which I'm really pleased he did, because there is an ambition, and Treasury expect this to happen, that the NHS will save 2 billion from procurement by the end of 2015-16. The 2 billion did not come from me, it came from Secretary of State. My calculations were that we thought that there was potentially around about 1 billion that could be saved. Dan Poulter didn't think that was ambitious enough. He made it 1.5 billion for the better procurement document without any science. I went on holiday, and when I came back, I found the number had gone to 2 billion because Secretary of State said that wasn't ambitious enough either. So I'm not going on holiday again soon. But that's the number that's been bandied around now since August last year. And as I said, there's no science about that at all. But actually, when you think about it, is a 10% reduction on 22 billion fair? Don't know. But the first thing Patrick Carter said was, I don't think you're going to deliver 2 billion by doing what you're doing, and you're certainly not going to deliver 2 billion by doing what procurement tends to do, which is focus on pricing. You've got to bring the demand and volume argument into this. So his view was he was not going to sign up to any kind of number until he'd done his own bit of due diligence on this. And his first question was, do we know how efficient NHS hospitals are, which I thought was a strange question to ask. So we tried to find out and realised that hospitals are not measured for efficiency. There's lots of good work goes on around efficiency, but there's no way that hospitals know whether they're any more efficient than the hospital down the road, because there's no standard measure of how you measure and look at efficiency. But he knew this, and he knew that other systems around the world did measure efficiently in a much more in a way that that the system understands and can act upon. So he asked us to go looking for all over the world, probably mainly America, to see how big hospital chains measure the efficiency of their individual hospitals. And I said he knew this, so he knew what we were going to find. And of course, what we found was that they all actually measure efficiency in the same way, and they all use a consistent measure. And that measure is AAs and PPDs, which is adjusted admissions or adjusted patient days. So that's taken into account, adjusted for activity, adjusted for case mix and different types of hospitals. But then you can start to attach the cost of a hospital against those metrics. And once you can do that, you can get a sense then of comparing hospitals, and they can get an understanding of their relative position, firstly. And secondly, once they know their baseline, they can then work to improve and reduce their costs. So we've been looking at how other systems around the world do this. They've been really good with us and showed us how they do it and where the data sources are to make these comparisons. And then we've gone back into the health system to look whether we can access the same kind of data. And the good news is 95% of the data is there. We've got some issues we're still trying to resolve, but we're very close now to having the first set of data of all expenditure in hospitals against those metrics. And I've seen a league table. I'm not going to expose that today because we're still very wary of it. But there is huge variation between hospitals around efficiency. What we want to do, though, is test that and get the NHS up with a bit of a sense of ownership for this. So we've identified 22 hospitals that we'll work with to start to apply this metric, start to look at the differences in the different cost areas. So, for example, comparing things like what's the agency cost per adjusted patient day, what's the pharmacy cost per adjusted patient day, and start to see the differences between hospitals. The 22 trusts have signed up. Half of them had no choice because they were trusts that were receiving financial support from the Department of Health, so they really had no choice in this. The other half, some of them are really big trusts, they just want to do this because I think it's a good thing to do. We asked them all for a nominated person that would become the college of experts that we want to help and take through this. Every single one of them, apart from one, nominated the finance director, which I think is interesting in itself. The only one that didn't actually was Hinchingbrooke, which is a private sector hospital, as you know, which nominated its procurement director, which equally was interesting. So we are now working with those 22 over the next few months. So the programme, the Better Procurement programme, has started to shift. It's now these three things. It's that focus on work on efficiency. By January, we'll have a better idea from the 22 what the real opportunity is for efficiency savings for the NHS. And it's at that point Patrick will make his mind up about whether he's going to sign up to any kind of number. His view is that actually there's probably more than 2 billion in terms of efficiency savings that can be made in the system if you look at the whole area of expense, and that includes pay. And I'll come back to that because that's changed the scope a lot of what we're doing. So that work is happening. However, Treasury, Cabinet Office, Secretary of State still expect that 2 billion is going to be delivered from procurement by 2015-16. So at the same time that's happening, we're still having to crack on with the things that we said we were doing anyway to help the NHS save that kind of money. And things like the core list, which I'll take you through in a So now the program is these three things. It's the metrics, it's efficiency, it's the first set of initiatives, and in time those two things need to come together. So you can see that a solution or initiative has a direct impact on the trust through the metrics that we're trying to put in place. So you start to get more of a pull for the solutions rather than being imposed on the system. And the third one is that we've now got to start thinking about that landscape as well. And the time is right now to look at procurement again. I have to say, back in 2006, when hubs were created, supply chain was created and so forth, very different system back then. The NHS had lots of money, very much trust being independent, make their own choices, and so leave it to the market to decide was very much the policy back then. I'm afraid that's not the case now, simply because of the financial situation. And there's a strong feeling that the centre needs to intervene to help the NHS with this. So the time probably is right now to have another look again at the operating model of the way procurement works in the system. So we have committed ourselves to looking at that over the next few months. So come back to the efficiency agenda and Patrick's view. Looking at all operating expenses, it means that we're going to look at everything. So it's everything from the whole of the workforce, the pharmaceutical costs, property costs and so forth. So this has dramatically changed the scope. So we're no longer talking about 22 billion, we're talking about 75 billion. Taken me and certainly my team well out of our comfort zone. And so there are people now coming into the programme who are experts in these fields. So the workforce policy people in the department are sucked in on the workforce. We've got a former HR director from a trust now leading this. And the same with pharmaceuticals, Dr. Keith Ridge, the Chief Pharmaceutical Officer, now he's leading that programme. So it's changed the programme quite dramatically. So in the meantime, we're still having to deliver the initiatives to try and save money urgently in this financial year and next financial year. I'm not going to go through all of these in detail, but I just wanted to briefly touch on the one on the left because, as I said, Secretary of State had this idea back in April, made the announcement. So guess what? That's the one thing he keeps asking me about, what we're doing about this. So every week we're getting asked questions, is this core list being delivered? And actually, this is really quite an interesting development, and it's not rocket science, and it makes so much sense. It's just how you do it across the whole of the system. Nobody would argue with the principle of a core list of kind of basic products that every trust is buying, where there really shouldn't be much argument, be it stationery or basic examination gloves or whatever, really. What we've seen is over the years, because we haven't really aggregated things up and then driven commitment into the supply base and then compliance into the NHS, we've had that drift of proliferation. And NHS supply chain catalogue, for example, there's something like 600,000 lines on the catalogue. And that's simply because of the nature of the beast. If trusts want to use something, supply chain will supply it. And supply chain could never really rationalise the range because trusts wouldn't use them. So it's a bit of a difficult situation for supply chain. So we need to put something into the system to change that relationship, and that's what we have been doing. So we've seen groups of hospitals now come together in some of those commodity areas and agree that they will rationalise down to one product, and they'll go with the decision. And guess what? It's had a dramatic impact on pricing. Which is probably not what suppliers want to hear, but that's exactly what's happening. But there again, that supplier is getting volumes, guaranteed volumes that it never got before. And I am talking 25, 30%. And that's enough to get people interested in making this happen. The difficult bit now is how do you make that happen across the whole of the system, and that's what we're wrestling with at the minute. And one thing we're looking at is could we short-circuit that approach of hospitals having to, one by one, buy into a decision. So the Department of Health is going to intervene itself and is going to guarantee the volumes to the winning suppliers. And that's quite a shift in thinking in the system. Richard Douglas, who some of you might know, is the Director General Finance in the Department of Health, at a meeting a few weeks ago threw a grenade into a meeting, which I didn't know he was going to do. which actually was an idea he got from some finance directors in the NHS, which was, why can't we make the call list free to hospitals? In other words, the Department of Health pay for it. All kinds of issues with that, but that's the kind of level of different thinking that's now going on in the system. Right, so I've mentioned a few of the other things. I'm guessing most people know now that the supply chain contract is due to come to an end in September 2016. So we're having a bit of a think about that, and it comes back to our thinking around the whole operating model. And our view on this is that, you know, we don't think the contract itself, that's not DHL and supply chain, we just don't think the contract itself is what the NHS really wants and needs. And that we need a contract that really works in the interest of the NHS and drives some things I've just described, things like call lists. So that's the kind of thing we're just trying to think through about how we do that. And in the meantime, I've been desperate not to lose sight of what we said from the outset, that we still need to help trusts improve on a number of fronts. And that are these things. The standards, which I've been absolutely amazed how they've been embraced by the system, despite my colleagues telling me how fantastic they are, and I say, yeah. But they have been really embraced by the system. And last night to me was eye-opening that, you know, it's really good to see people celebrating now when they are making progress on the standards. Other things maybe slightly more contentious. The one on the bottom there, which, again, these things happen with ministers. They have an idea, and transparency is a big idea that ministers have. That why can't we just throw data and information out and let the public decide? And if you ever have a look at the My NHS website, and I would urge you to have a look at that. It's quite an interesting website. It enables you to compare hospitals on a number of fronts, mainly quality measures at the minute, things like mortality rates and infection rates and so forth. But increasingly, there's a section called efficiency, which we're now being asked to sort of contribute to. And as part of that, ministers had the idea, why can't we just throw out what trusts are paying for certain goods and services and expose the difference and stuff? And, you know, we knew that this was going to be a problem because there's so much complexity around this, there's rebates, all kinds of things that go on around this, but we had no choice. That's what ministers wanted. So we threw out this thing called the Atlas of Variation, which went down like a lead balloon, I think is probably fair to say. But actually, the important thing with that is the principle of transparency and putting this data out in the public domain to start getting people to ask questions. And the second iteration of that Atlas of Variation goes out today, so I'm expecting more flack. And then the final thing is we knew we need to help the NHS start to share information, data. So we built a portal for the procurement community at this stage, which is the CPE portal. So if you didn't know this, this is really well used. Again, it just amazes me that there is a real willingness now for procurement people across the NHS to share and talk. And some of the debates on there have been fantastic. So that's been a real success, actually. And that's not the Department of Health. All we've done is put the tool in place. It really is owned by the NHS, and they are using it. We also used it to, we asked every trust to nominate a non-exec director to champion procurement, and they virtually all did. And again, we built a part of that for them to share information about how they could help and champion procurement. So this is what we're trying to do about getting stronger leadership in the system. So finally, innovation. Well, as I said from the outset, we've got some real financial challenges for the NHS. I think Simon Stevens' document really summed it up well. Some of the stuff Will Cavendish is now saying is that innovation, you know, is the only thing that's really going to save the NHS going forward. That's kind of manifested itself in a new innovation, growth and technology director in the NHS, which I think in the Department of Health, which I think is really good. Life sciences particularly is an important sector. It's critical to the economy and it's critical to the NHS, which is why we've now got the Office for Life Sciences. And we have an Office for Life Sciences minister. So we have a minister dedicated to that, which again is really good and welcome. And then innovation and procurement. And, you know, I've been on the end of a lot of criticism over the years from governments, from ministers, and BIS particularly, the Department for Business Innovation and Skills, that says that NHS procurement is a pain, it's blocking innovation, and that actually it could be such a promoter of innovation. And whenever I've gone back and said, well, tell me how to do it, they can never tell me how to do it. Because nobody really knows how to do this. My own view is, I think it's those three things. The first one is absolutely to make sure that particularly SMEs do not get blocked out. They have that opportunity to win business in the system. And that's simple stuff, actually. It's just creating that level playing field, making sure, you know, tenders and everything else, there's no burdens there, and constantly filling in PPQs, all that kind of stuff is removed. In actual fact, Lord Young is taking care of this anyway, so it's actually going to come through a bill. So it's going to be mandated in the system, so that's kind of welcome news, I think. That's the first thing, which it just should be taken as a given. That just has to be done. The second thing, then, is how does the NHS respond to innovative ideas from industry? And it's always struggled to do this. And Serene Cutter's report, Innovation, Health and Wealth, recognise the need to be an architecture built in the system to be able to do this, and that's why we have AHSNs. And that's why I think AHSNs are really, really important. They've got to start thinking about how they help NHS respond to these innovative ideas from industry. And the final one is probably even more of a challenge, is that, you know, we've got known problems in the system, so how does the system articulate those problems to industry to pull innovation? And we've had things like the SBRI program, which I guess has shown this is doable. Sometimes I think those programs have been a bit too detached from the system. And again, that's where I think AHSNs have a real strong role to play, about how they articulate the need for a solution. And finally, just to say that, you know, all of this, it's the suppliers, it's the SMEs that need to respond as well. So SMEs are really important to the future NHS. I think that's probably all I wanted to say. I've probably gone well over time, so apologies for that. But I hope this gives a bit of a flavour of some of the issues facing the NHS.